Part 3 in the series on the most important things RCPs must know about mechanical ventilation. We'll be discussing scalar waveforms. My name is Bill Miller, and I have no conflicts of interest to disclose with regard to the subject matter of this presentation. After graduating from the respiratory therapy program at Butte College in Northern California, I moved to Sacramento and began working at the University of California at Davis Medical Center. And I worked there for 30 years and retired. While I was working there, I was also working at a Kaiser hospital. I worked there for 7 years. And about 25 years ago, I started teaching mechanical ventilation at Napa Valley College in Napa, California. I also teach at American River College mechanical ventilation in Sacramento. When our ventilator is ventilating the patient, the ventilator gives us a lot of information numerically, but also it gives us information graphically. And using the graphics, it enables you to optimize the ventilator settings for the patient, make the patient more comfortable, and make the patient synchronous with the ventilator. You know, if the ventilator is not in sync with the patient, or the patient is not in sync with the ventilator, the numbers don't tell us that. The numbers tell us a lot of valuable information, but we can see the same information looking at the graphics, plus much more. Today's ventilators come with graphics, but they're not useful if we don't look at them or if we don't understand what they are telling us. Scalar waveforms plot a respiratory parameter against time. This top one here is the pressure, and this shows the inspiratory pressure, and this shows the expiratory pressure. The volume versus time scalar waveform shows the volume going in and then the volume coming out. The flow versus time waveform shows the inspiratory flow and the expiratory flow. This says minus 50 and minus 100. That they're not really negative, it's just flow in a different direction. So this flow up here is going into the patient, and this is the flow coming out of the patient. In this example of a volume versus time scalar waveform, we see that on the volume axis, the volume is in milliliters, 200, 400, 600, 800. Now you can change this to liters if you like, and some equipment that you'll be using may show this in liters, so it would be 0.2 liters, 0.4 liters, 0.6 liters. It's just a matter of where you put the decimal point. Now on this axis is time, and this is called the sweep. The sweep in this instance is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds. So we have a 10-second sweep time. In this example of a flow versus time scalar waveform, we see the flow is in increments of liters per minute. You can change this on your machine to show liters per second. So 30 liters a minute, it would say 0.5 liters per second. On this axis, on this example, we see 48-second sweep, and these are not 1 second, these are 8 seconds, 16 seconds, 24, all the way up to 48 seconds. And you notice here that these waveforms are bunched up real close together, and it's hard to see the fine details that you need to be observing when you're trying to analyze your waveforms. Here's what it would look like if you had a sweep speed of only 3 seconds. You see large pictures of breaths here, and you can see lots of detail, such as in this one where the flow does not get back up to the baseline flow, and that would indicate air trapping. The sweep in this example is 30 seconds. You see 1, 2, 3, 4, 5, 10, 20, 30 seconds. So you're seeing a full half minute's worth of breathing, and now you can tell that this patient is in a SIMV, because here is a mandatory breath, and here's a spontaneous pressure supported breath, a spontaneous pressure supported breath, and then a mandatory breath. In these scalars, we can see that the flow is in liters per second, not liters per minute. The dotted line here is 0, so that means there's no flow right here. And this is the inspiratory flow, and this is the expiratory flow. The flow goes up to, at the top of the scale, is 1 liter per second. And so this must be 0.5 liters per second. 1 liter per second is 60 liters per minute. 0.5 liters per second is 30 liters per minute. So you can see the flow going into the patient is at 0.5 liters per second or 30 liters per minute. And the expiratory flow goes down to a peak of about 0.5 liters per second. On the volume scalar, we see it is displayed in liters. So the dotted line is 0, and here is 0.2, 0.4, 0.6, 0.8 liters. Or that you could look, it would look the same if it said 200, 400, 600, 800 liters. Now the pressure is always going to be displayed in centimeters of water pressure. The sweep on this scalar is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds. So let's look at some examples of this volume versus time scalar waveform. It's the simplest one, but there's really a lot more to it than just the air goes in and the air comes out. But basically, that's what it's showing. The line that goes up is the inspired volume, and this is the expired volume. This is the volume that goes into the patient, and then the expiratory valve opens on the ventilator, and the inspiratory valve closes, and the patient exhales. We see here a tidal volume of about 300 goes in. It goes from 0 up to about 300, and then when it comes back down, we want to see it come all the way back down to this line because it goes from 0 to 300 and then 300 back down to 0. If it doesn't make it back down to 0, then the patient has lost some of that tidal volume somewhere. Here we see that the tidal volume is about 500 and the inspiratory time is about 1 second. This sweep is 1, 2, 3, 4. This is increments of 1 second each, so that's 10 seconds. And can you tell by looking at this what is the expiratory time? Inspiratory time 1 second. Expiratory time is... One might think that the expiratory time is 2 seconds because you see here the air goes in 1 second and the patient finishes exhaling in 2 seconds. However, there's a little bit of a pause before the next breath. And so this is all counted as part of expiratory time. So the expiratory time here is 1 to 3 seconds. So the IE ratio is 1 to 3. So if the inspiratory time is 1 second and the expiratory time is 1 to 3 seconds, that means our cycle time is 4 seconds. And if the cycle time is 4 seconds, and since there are 60 seconds in a minute, 60 divided by 4 would be 15. So the respiratory rate here is 15 breaths per minute. In this example, there is no pause between inspiration and expiration. At the end of inspiration, the expiratory valve opens and the inspiratory valve closes at the same time, so the breath immediately becomes an exhaled breath, and it normally is a passive breath, and so you see the time that it comes out is longer than the time that it goes in. We set an inspiratory time on our ventilator, but the expiratory time is passive and depends on things like the airway resistance and the compliance of the lungs. Now, there is a pause at the end of exhalation, the patient's exhalation, and this pause here is also normal. It is normal in patients who are not sick and on a ventilator feeling air hungry or short of breath. Often you will see the patient, the air goes in, the air comes out, and right away the air comes back in. That's not a good sign, but it's a real common thing to see on a ventilator. Normally though, when we're breathing quiet, spontaneous breathing, we exhale and then there's a little pause before we take the next inspiration. Looking at the volume scalar on this waveform, we see that there is not a pause after exhalation. You also see that this patient is breathing a very small tidal volume. If this is 200, 400, 600, 800, his tidal volume is not even 200. And his respiratory rate must be fast because you see his cycle time is only about 1.5 seconds. So this patient is breathing a breathing pattern we call rapid shallow breathing. And that is not a healthy breathing pattern. It often indicates that a patient has fatiguing respiratory muscles. It also is a breathing pattern you'll see with patients who have low lung compliance or low chest wall compliance. Another thing to note here is that the tidal volume is just a little under 200 every breath. You see how there is very little breath-to-breath variation in the tidal volume. And that again is how people who are sick, people who are having a hard time breathing on the ventilator, you see the tidal volume is almost the same every breath. When you and I are breathing comfortably, not intubated, not sick, not in the hospital, our tidal volume varies pretty significantly from breath to breath. It can be 40% variation and be very normal breathing. So when you see no pause after exhalation and a tidal volume that is almost the same every breath, that is not a good sign. This spontaneously breathing patient is breathing about 30 breaths per minute. You see, this is 10 seconds, remember? And if we see 1, 2, 3, 4, 5 breaths in 10 seconds, then this patient must be breathing 30 breaths per minute. His tidal volume is almost 400. So this is not rapid shallow breathing. This patient is breathing a big minute ventilation because if you multiply his respiratory rate times his tidal volume, you get a minute ventilation of about 12 liters. That means he has a high ventilatory demand. And he doesn't pause between breaths. This guy is breathing in, out, and really can't breathe any faster without even trapping even more air. So this is not rapid shallow breathing. This is rapid and deep breathing, and it could be caused by a patient might have a metabolic acidosis that he's trying to compensate for. It could be an increase in dead space ventilation, or you could be hypermetabolic, burning too much oxygen and making too much CO2 and has to breathe a big minute ventilation to eliminate all that CO2. This patient's tidal volume is just under 200 milliliters. That's a very small tidal volume. If he could breathe a bigger tidal volume, he would, but obviously he can't breathe a bigger tidal volume, so he must breathe 36 breaths per minute to try to get the minute ventilation that he needs. He needs more ventilatory support. If he's on pressure support, he needs more pressure support, or he may need to be put in assist control or whatever. He needs more help from the ventilator. You should never let a patient be breathing like this. This volume scalar is showing that the volume on inspiration is greater than the volume on exhalation. 400 milliliters go in, but when he exhales, it doesn't come back down to zero. So that means that there was about 100 cc's of the tidal volume was lost somewhere. Now, it could be a cuff leak, and this is common. The ventilator's delivering a breath, and under pressure, the cuff leak becomes worse. This 400 is being delivered under pressure. So 400 may be going down the ET tube, but some of it is leaked around the cuff so that the patient only gets 300 of that 400, and so he exhales only 300. And that might be due to a cuff leak. This can also be due to a bronchopleural fistula. The patient has chest tubes, and you see bubbling on inspiration, and that bubbling is the air that is not going to be exhaled, is going out through his chest tubes, so he's losing 100 there. It can be a problem in the ventilator circuit somewhere, the humidifier. There is a leak. And so you probably should try to figure out where the leak is. Would be considered a 25% leak. So let's talk about the pressure waveform and look at some examples. This is a pressure waveform with a patient in volume control. So with the breath is delivered right here, and you see the pressure climb until this point right here where there's a changeover from inspiration to expiration. The inspiratory valve closes, the expiratory valve opens, and the pressure falls very quickly back down to the baseline. And this baseline pressure here we can see is about 3. That is the PEEP. So we have the PEEP and the inspiratory pressure, the peak inspiratory pressure, exhalation, and back to the PEEP level. The shape of the pressure waveform is determined mostly by the flow delivering that breath, or how that breath is being delivered. And in this example right here, the flow is constant. So this is volume control. We're controlling the volume, and so we have a constant flow all during inspiration. And when we have constant flow, then the pressure is not going to be constant. It's going to climb all during inspiration till the end of inspiration and the patient exhales back down. Over here, this waveform looks a little different, but these are both volume control, but this breath is delivered, volume is delivered in a different way. Here we have the flow is using a ramp wave, or the what is often called the decelerating flow. So when the flow is much lower toward the end of the breath, there's less pressure. So we almost look like we have a pressure control where the pressure would be constant. But this is not. This is volume control. And so let's take a look at pressure versus time scalar waveform. Here is our pressure waveform in pressure control. And you can tell we're controlling the pressure because the pressure is staying constant all during inspiration. And so the waveform, the pressure waveform, is pretty flat on top in most cases. We see the flow is decelerating as the lungs fill. The flow to keep that pressure becomes less, and until the point where exhalation begins. Let's also take a look, while we're looking at this pressure control waveform, the volume. Remember, when the volume going in is greater than the volume coming out, you must have a leak somewhere. So this is the volume going in. It says 350. And then when the patient exhales, it doesn't come back down to 0 again, and then the next breath starts at 0. So there is a small leak here. I would suspect that this leak is caused by these extremely high pressures on inspiration. This patient has a pressure control of 69. And we would never do that today. These waveforms here were generated back in the 1990s before we learned about lung protective ventilator strategies. I would also like to point out here what's going on with the tidal volume waveform when we do an inspiratory hold. When we do an inspiratory hold, of course, we stop flow, and if there's no flow, there's no volume going into the patient, and there's no volume coming out if the expiratory valve is closed. So you can see the volume goes in, and instead of coming to a point like it normally does, it's blunted, it's flat on top. So this period right here is where there is no flow, and where we're holding the pressure constant to measure our plateau pressure. Another pressure we can look at on our scalars is the inspiratory hold plateau pressure. You see here we have looks like about a PEEP of about 5, and then on inspiration the pressure goes up to a peak inspiratory pressure of probably about 38. And then instead of letting the patient exhale, we do this inspiratory hold maneuver where we close the inspiratory and expiratory valves, and flow stops. There's no flow going in or out of the patient. And so we get what they call a plateau pressure. And even though this is airway pressure we're seeing right here, we know that this is also alveolar pressure because there is no flow. If there's no flow, there must not be a pressure gradient between the upper airway and the distal airway. And so This plateau pressure is used to assess the pressure inside the lung. This pressure here, of course, is inside the ventilator, outside the lung, and is not as important as knowing what the plateau pressure is. Here's another example of pressure control. Inspiration begins and the pressure is held constant all during inspiration, and the flow has to decay down to wherever it gets to when inspiration ends, because this is going to be timed. We're going to set this time. Now, in this instance, we see that the flow goes down to 0, and then there's a bit of a pause before the patient exhales. This is the same thing as doing a inspiratory hold maneuver. And you see what's happening with the volume. The volume goes in and it's flat on top here instead of coming to a peak. That's where there's no more volume going in. And so what this is telling us is that we have our inspiratory time set longer than necessary. We can decrease our inspiratory time back to about here and still deliver the same tidal volume. So let's talk about how we might use this at the bedside when the patient is on the ventilator and we're ventilating with pressure control. Let's say, for instance, here the physician wrote an order and the appropriate tidal volume is about 400 milliliters. We need to deliver 400 milliliters. And so we put this patient on the ventilator with pressure control with a peak pressure of 23. And when we do that, we only have a 298, a 300 tidal volume when we want a 400 tidal volume. So if you see here, the flow is still going in the patient when inspiration stops. We could lengthen inspiratory time and deliver flow for a little bit longer. And remember, flow times time equals volume. So let's try increasing our inspiratory time a little bit here. Okay, so now our flow goes on for a little bit longer. We lengthened our inspiratory time, and our peak pressure is still 23, but now we're getting a 373 tidal volume. So can we get more tidal volume by lengthening inspiratory time a little more? Let's see. Well, the answer is yes. We lengthened our inspiratory time even longer, and we were still having flow going into the patient, almost gets down to 0. And our pressure is still 23. So for the same pressure, now we're getting a bigger tidal volume. So we got a bigger tidal volume in pressure control without turning up the pressure. We just used our waveforms to find the right inspiratory time to deliver that tidal volume. So now if we lengthen our inspiratory time more, will we get more tidal volume? Well, not much. We went to 414. Our pressure is still the same. But remember, down here, there is little or no flow, so it's not going to increase the volume very much if there's not very much flow. Now, also, let's take a look at our volume waveform. See how it's starting to flatten out on top? It doesn't come to a sharp peak like normally. So let's see what happens when we increase our inspiratory time even longer. So now we got this pressure going on for this long, and we see that the flow had reached 0, no more flow going in. And so right here is a period during inspiration, or after the volume has been delivered, where there is no flow. And now look at our volume waveform. It is flattened on top. Now this just looks just like what you would see when you do an inspiratory hold maneuver. And it is what you would see, and that tells us that since there's no flow, no more volume going in or out, airway pressure and alveolar pressure will be the same. So when you have this pressure control breath being delivered like this, you don't need to do an inspiratory hold maneuver to check compliance and plateau pressure. Because you'll see it on every breath. In addition, the pressures from the ventilator are not helpful for cardiac output. So the less pressure for the less amount of time, the better. So this patient is probably not benefiting from having his inspiratory time set this long, because at this point right here, there is no more volume being delivered. And you can see there's no more volume being delivered. Looking at our volume curve, it's just staying the same all during that period. So to find the right eye time in pressure control, usually we can just watch our waveforms and increase the eye time in pressure control, watching the flow. When the flow stops going in, then we're not going to get any more volume at that point. So now let's talk a bit about the flow versus time scalar waveform. We see on this axis over here is the flow rate, and this one is in liters per minute. So we have 30, 60, 90, 120 liters per minute. And then down here is the expiratory flow. Everything below this line of zero is expiratory flow. Sometimes you will see this say minus 30, minus 60. It's not really a negative number. It's just flow going in a different direction. So this flow here is going down the ET tube. And when the inspiratory valve closes and the expiratory valve opens, the pressure falls to zero, in this case, because there's no PEEP. And so the pressure falls very quickly because there is some pressure built up in the ventilator tubing, and so that volume has to be exhaled first. So here, this is the ventilator exhaling down to here, and that's actually the tubing exhaling. And here is the patient's exhalation right here. He exhales, the flow gets slower and slower and slower, and then when he gets up to the zero flow, then the air is not coming out anymore. Now you see there's two different flow waveforms we're looking at right here. This is called the square wave, or rectangular, or constant flow, because you see as the instant inspiration begins, the flow is limited here at whatever flow rate you have set. In this case, it looks like it's probably about 40 or something. And over here we have the flow. This is how this breath is delivered a little differently. So here the flow comes out to whatever the flow rate you have set, but the flow is going to decelerate all during inspiration. So this is called the ramp wave, and some call it the decelerating flow waveform. And again, you have exhalation. So the inspiratory part of the flow curve, especially in volume control, looks like what you would expect it to look like, because this breath is being delivered at a flow rate of 40 liters a minute, or whatever that is, for an eye time of, it looks like about about 0.6 or 0.7 seconds. And then the patient exhales. This breath is going to last longer if the peak flow is set the same and the tidal volume is the same, because this flow is only at the very beginning of inspiration, but as the breath is delivered, the flow slows down until it gets to almost zero, and then the patient is allowed to exhale. Some ventilators offer different ways to deliver the flow to the patient. This waveform here is called the sine wave, and this is seldom used that I've seen, but I believe some people probably use this. It should be the most physiologic way to deliver a breath, because when we breathe spontaneously, our peak inspiratory flow is in the middle of the breath, and that's the purpose for this kind of a design. But since you have slow flow at the beginning of the breath and slow flow at the end of the breath, it makes inspiratory time much longer. And this waveform is available on some ventilators. Here's a patient breathing spontaneously, and you can see here that he hasn't any pressure support, and he doesn't have any PEEP, because this dotted line here is zero. So he's just breathing spontaneously with no ventilatory support. And if we look at this flow curve, we see that this patient breathing spontaneously with no assist from the ventilator has pretty much a sine waves the way he breathes. So this is a kind of a physiologic way people breathe. Note that the peak inspiratory flow is in the middle of inspiration. When we deliver a breath to a patient, we want to give the patient enough time to exhale all of that breath. If they don't exhale all of that breath, then they trap air. And we can see that that is the situation right here. Here is the peak expiratory flow, and the flow is going back up to where the patient would be completely finished exhaling, but he doesn't get there. Right here, the ventilator delivers another breath. So since there was flow coming out of the patient at this point, that means that alveolar pressure was higher than airway pressure. And that, by definition, is autopeep. Autopeep means that the alveolar pressure is higher than airway pressure at the end of exhalation. So we don't know how much autopeep we have, but we do have some autopeep. And this autopeep is caused by the ventilator not letting the patient have enough time to exhale. We can also have autopeep in patients trapping air when they have airflow limitation, such as with asthma or COPD. But their curve will look a little different. The peak expiratory flow won't go down as far, and then you'll see the expiratory flow tracking along, never getting back up to baseline. And here's another example. The expiratory flow does not make it back up to the zero flow line. So there is flow still coming out of that patient when the next breath comes in. Now, we can remedy this by sometimes we can just shorten I time a little bit to lengthen E time. In this situation right here, it looks like the I time is already pretty short, and so maybe the best way to give this patient more time to exhale would be to decrease the respiratory rate on the ventilator, and that would give him more inspiratory time and expiratory time. The peak expiratory flow rate is shown on our waveform. On the expiratory portion of the flow curve, you see the flow comes way down to here, and exhalation. So the peak expiratory flow rate is helpful, especially with COPD and asthma patients. If you have an asthma patient and his peak expiratory flow is 30 and the next day it's 20, he got worse. So this is not the same peak expiratory flow rate we use with our peak flow meter or when we're doing PFTs. This is not a forced maneuver. This is a passive exhalation. So this is just where the peak expiratory flow goes to when the patient exhales passively. And you have to be careful because this looks like the peak expiratory flow is way down here when actually it's not. It's up here because what's happened is the ventilator is creating pressure in that circuit during inspiration, and then when the expiratory valve opens, it releases that pressure that's in the ventilator circuit, so you see it spike like this. So this is the tubing exhaling, not the patient. The patient's expiratory flow would be somewhere about right here, because here you can track his expiratory flow right here. Another thing we want to look at with the flow curve on the expiratory portion, especially with our COPD asthma patients, is the end expiratory flow. The end expiratory flow is the flow that is coming out of the patient when the next inspiration begins. So if that's zero, then we're not trapping any air. But if it's more than zero, then that means that the patient didn't finish exhaling and we have trapped some air. And here's an example of that. Here is the expiratory flow. Now this is the tubing's peak expiratory flow. The patient's expiratory flow, the peak would be somewhere right in here, because if we just draw a line here and extrapolate that line, we can see about where the patient's peak expiratory flow rate is. So to get good at ventilator waveform analysis, requires that you get some instruction. It isn't something that you can just start looking at ventilators and figure out all this stuff about the waveforms. And there are some good books out there on ventilator waveform analysis. Also, there are YouTube videos to watch that will be very helpful in giving you the kind of instruction that you need. But practice is where you're really going to learn ventilator waveforms. Consider a child taking piano lessons. He goes for 30 minutes once a week to get instruction, and then during the week he does the practice. So he practices an hour a day, 2 hours a day, whatever. And so that is where the person learns to be a good piano player. Now, the other thing that you have to have is the desire to learn to interpret these waveforms. Take again, kids taking piano lessons. You have two 10-year-old kids taking piano lessons from the same teacher, and the teacher's teaching them the same stuff, and they are each required to practice when they go home. And one kid, the parents make him practice. He hates playing the piano. He doesn't want to take piano lessons. He has no desire to learn to play the piano. The other 10-year-old kid, however, loves playing the piano, and then nobody has to tell him to go practice. So which one of those two piano players are going to be good when they get older? Well, the one who has the desire to learn to play the piano. And it's the same with the ventilator waveforms. You need some instruction, you need a lot of practice, you need to look at hundreds of waveforms on hundreds of patients over a long period of time. And you have to have the desire to learn waveforms. And I think you already have the desire, you wouldn't be watching this video. So let's do some exercises here. Let's look at these scalar waveforms right here and see if we can tell about this patient and about the ventilator and the ventilator settings. And let's start up here with our pressure curve. We see that our peak pressure is going to about 30, and we see our PEEP is down here around probably 5 or something. And can you tell what mode this patient is being ventilated in? What is the mode and what are the breath types? Well, I can tell you the breath types are volume controlled, because see here, you can see where we're controlling flow. And so this must be volume controlled breaths. But what are these little breaths in between here? Well, this patient is in SIMV with pressure support. So this is a pressure supported breath and this is a pressure supported breath. Looks like a pretty low level of pressure support. And can you tell what the respiratory rate set on the ventilator is, the SIMV rate? Well, since this is 30 seconds, right? Here's our sweep is 30 seconds. And we see 1, 2, 3 mandatory breaths, volume controlled breaths in 30 seconds. So if we extrapolate that to a minute, that would mean that the respiratory rate is 6. So this patient is on SIMV of 6 breaths per minute. And how much spontaneous breathing is the patient doing? Well, it looks like 2 breaths for every ventilator breath. And if that's consistent, then the spontaneous respiratory rate must be 2 times the ventilator set rate. So this is 12 breaths per minute spontaneous and 6 breaths per minute mandatory. So the total respiratory rate here would be about 18 breaths per minute. And when we look at our flow scalar, we can also see the difference in the breaths. Here's our volume controlled breath with constant flow, square flow wave, and the patient exhales, and then here's our spontaneous breath. Remember, if you have a machine, a mode, or a breath type that you're delivering at constant pressure, then the flow will be decelerating, whether it's a pressure controlled breath or a pressure supported breath. Down here on our volume curve, we can also see that there's a difference in the breaths. Here's our mandatory breath. It looks like a very big tidal volume, 950. And then these spontaneous pressure supported breath is not very much pressure support. The patient is breathing spontaneously. So his tidal volume is much lower. It's probably about 400 or something tidal volume. So if we were to calculate the minute ventilation, we could do that by looking at our tidal volume for our mandatory breaths, 1, 2, 3, 4, 5, 6 times 951, and then add to that the spontaneous breaths, which are about 400, and there are 12 of those per minute. So 400 times 12, that would be 4.8 liters. You just add those together and you got the minute ventilation. Also, we can see a leak, but the leak is only after the mandatory breaths. You see the spontaneous breaths, there's not very much pressure here, so it's probably not enough pressure to cause the cuff leak that's going on here. So a little bit of a leak on this breath, and this breath, because these breaths are under a lot higher pressure. So you would expect the leak to be on the breaths or the under the most pressure. And so can you tell what this patient's expiratory time is and inspiratory time and IE ratio? Well, let's looky here. These dotted lines coming down like this are 1 second apart. So if we take a breath that looks like right here, starting at about on the 1 second line, this tidal volume, this respiratory pattern we're seeing here is short inspirations and normal exhalation. In other words, our IE ratio looks to be about normal. So we have a short inspiratory time, but again, we have a respiratory rate of 20, so we need to give the patient time to exhale, and even at that, we're not quite exhaling all of our volume. When we look at the expiratory time, that's from the end of inspiration to the beginning of inspiration on the next breath, and so that appears to be about 2 seconds approximately, and probably a couple of tenths of a second more than that. Here's another exercise. What mode of ventilation is this, and what are the breath types? Well, we see the pressure is held constant during inspiration. It's not perfectly flat up there, but sometimes you will see that. The inspiratory time and the expiratory time are what? Any guesses? How about 1.5 seconds on inspiration? And what's expiratory time? Looks like about 1.5 seconds. So what's our IE ratio? Our IE ratio is 1 to 1. Are we trapping air? Yes, we are. We don't have enough time for exhalation here, because you see the flow is still coming out of the patient when the next breath comes. We can also see that there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 breaths, so the respiratory rate must be 20. Our tidal volume is around 900, and that's a pretty big tidal volume. But if we multiply our tidal volume times our respiratory rate, we get the patient's minute ventilation. So this is about 18 liters per minute, and that's a very large minute ventilation. You should try to figure out why your patient needs such a big minute ventilation. So what would you think if you discovered a volume waveform that looked like this? There's a volume going in, looks like about 400, and here's the volume coming out. He exhales his 400, plus he exhales another 100 or so. And then here the same thing happens on this breath. How can a patient exhale more than he inhales every breath? Well, he can't. And so something here is not being truthful, and it's your ventilator graphics, because you cannot exhale more than you inhale every breath. What is happening when you see this waveform is that there's a problem with the ventilator. It's not accurately measuring. And it's almost always the expiratory side of the ventilator. The expiratory side of the ventilator is moist air, and can things like a wet expiratory filter or flow transducer. Also, the ventilator can not be calibrated properly or drifted out of calibration. Uh, Another thing to be aware of here is that your ventilator is going to tell you that this is the exhaled tidal volume when it really isn't. So especially if you're in pressure control and you're not setting a tidal volume, you just set a pressure, then you look at the expired tidal volume to see what tidal volume the patient got. And the ventilator will read numerically what that tidal volume is, exhaled tidal volume. But it's going to tell you the wrong number when you see the tidal volume going down below baseline like that every breath. So here we have a patient who is in SIMV with volume-controlled breaths and pressure-supported spontaneous breaths. It's not real easy to see that because these waveforms all look pretty similar. But if you look carefully, remember it's the fine details. This breath right here, the flow is constant all during inspiration, which looks like it's about 1 second. And then this breath doesn't look the same. This breath is a pressure-supported breath, so the flow decelerates during inspiration. So you have a mandatory breath, a spontaneous breath, a mandatory breath, and a spontaneous breath. Looking at the tidal volume, you see also on the spontaneous breaths, the tidal volume is a little less than it is on the mandatory breaths. You also see on the pressure curve, the patient is trying to exhale before inspiration ends. So this last part of inspiration, he is trying to exhale and it's pushing that pressure up. So the pressure is climbing and then it climbs more steeply. And so that is a patient who is not synchronous with the ventilators because the ventilator has a set I time that is not the same as the patient's neural I time. Now, we see the same problem here on the pressure-supported breath. You see, and you remember, it's fine details. There's a little bump right there at the end of inspiration, and that's the patient trying to stop inspiration from that pressure-supported breath. It's a little more noticeable on this spontaneous breath, but still, there's this spike right there. This patient is not doing well with pressure support. These pressure-supported breaths are not really working for this patient. So you might want to consider just putting him in assist control until he improves somewhat. Sometimes, though, in pressure support, you can increase the expiratory sensitivity up a little bit higher. But it looks like he's already truncated it quite a bit. It looks like about 50% of the peak expiratory flow is where the breath terminates. But it terminates way up here because of this spike in the pressure, him trying to exhale during inspiration. Here's an example of an asynchrony that is we call missed triggers. The patient made an inspiratory effort but failed to trigger a breath. And we can see this patient has 3 missed triggers in 10 seconds. This is a missed trigger, this is a missed trigger, and this is a missed trigger. What it looks like the patient exhaled and then exhaled again. People just don't exhale twice after one inspiration. This right here was an inspiratory effort, but the patient was unable to create any inspiratory flow or drop the pressure, and so he did not trigger a breath. We look at our volume curve, we see the volume that went in is about 400, and then he exhales 200. He makes that inspiratory effort, and then he exhales 200 more. This type of dyssynchrony is really common, and it's caused by often COPD patients have this air trapping problem like this, and you'll see this on those patients. And also patients with pressure support set higher than is reasonable for that patient. And sometimes that might only be like 12 or 14 of pressure support. So how do I know for sure that these are missed triggers? Well, what we can do is we can look at these same waveforms on the same patient, except we're going to add down here another set of waveforms called the esophageal pressure waveform. So right here is our esophageal pressure waveform. If we put a manometer in the lower esophagus, we measure changes in pleural pressure. That's because changes in pleural pressure are reflected across the thorax, and since the esophagus is a thoracic structure, we see the changes in pressure the same here as we would see if we had a manometer in the pleural space. So the reason why I'm showing you this is I'm not going to try to teach you about esophageal manometry right now. It's a humongous subject, but I wanted to show you this because this is a way I can demonstrate that these were indeed missed triggers. You see, here's a patient's inspiratory effort, inspiratory effort, inspiratory effort. Well, when he made this inspiratory effort, he didn't trigger a breath, but he did make an inspiratory effort, a very obvious inspiratory effort. And the same thing here, and the same thing here. So this type of dyssynchrony is uncomfortable for the patient. It's not helpful to the patient. And another problem with this is that the ventilator is going to report a respiratory rate based on the breaths that were triggered, right? So the ventilator would say that this guy's respiratory rate is 24 breaths per minute. But since it's not counting this one and this one and this one, this patient's actually making 42 inspiratory efforts a minute. But it's not going to be recognized by you if you're not looking at the waveforms, and know that this, when it looks like the patient exhaled twice, that is usually because of a missed trigger, and the missed trigger can be caused by Autopeek. Patients with COPD often have a lot of air trapping, and another type of patient that will frequently be seen doing these missed triggers is a patient with a high level of pressure support. If the patient is trying to breathe 30 times a minute and we increase his pressure support to try to get more tidal volume, we're going to force a longer spontaneous inspiratory time on him because the pressure is going to be higher. And that will decrease his expiratory time. If he continues trying to breathe 30 breaths per minute, he will have these type of missed triggers. He will be having air trapping, Autopeek, dynamic hyperinflation, goes by a lot of names. Well, we've come to the end of this talk on introduction to ventilator waveforms. In the near future, I will be posting more of these ventilator waveform videos. They will be called Exercises in Ventilator Waveform Analysis, and it will be a lot of waveforms from real patients, and we will look at them and see if we can figure out all the problems and what we might do with our ventilator to remedy those problems. Thank you for watching.